Well, welcome to AI Live, you guys. We have fun here. And we have some stuff to go over with you before we start, but we have a really good topic for tonight that we're going to kind of discuss and look at pigmentary disorders and things and talk about pigmentation issues and what we need to know about that. So tonight's topic is myths about pre and post-treatment care. Now, we do have a lot of myths around some of the things that we do. We do. So we want to kind of discuss this a little bit, and feel free to type in your in the comment box, kind of if you have any comments about this stuff. But it's been interesting. We hear a lot of myths about this, and hopefully we can dispel some of these today.
All right, so we're gonna jump into this. Myths versus facts, debunking misconceptions, maybe some protocols, patient safeties, and how to maybe optimize your treatment outcomes with your patients. You know, everything is about talking to your patients, setting the right expectations, because when you set the right expectations for your patients, you lead to a lot less issues with the patient. They expect it, and if it comes out better than they expect, you are the golden person to do everything for them in the future. So first one is neurotoxins. I think this one is the one that is the most misconceived with regards to neurotoxins. I think I hear so much stuff about neurotoxins, and after this, don't do this, don't do this, don't do this. And what do you say about all of that, Lori?
It drives me crazy. And I think number one, we have to know the research. Know your research, know the facts. Number two, use your common sense and critical thinking. So, say you work out before you get injected. Can it ruin your results? Well, I don't think anybody's going to walk into my clinic still sweaty, beet red-faced after they worked out. They might have worked out a couple hours before. I usually don't get people, a lot of people come in their workout outfits, but not all with their blood pressure high and their face all sweaty. So,
and even if they did,
working out before, no, it's not going to do anything. It won't. That's a myth, because you're not going to have vasodilated vessels in this big pink face, and you're not going to have that where you have the potential for more extravasation of the neuromodulator to be just kind of carried away in the vessels. So I'm not. That's baloney.
Drinking acidic juice. I don't think that has to do with that.
Drinking acidic juice, like orange juice, will help break down lidocaine. We don't use lidocaine in neuromodulators.
I don't know why we put that there.
So I don't know. That's a myth. There's so many myths out there.
But laying down after treatment, I hear this time and time again. Hopefully you guys are not telling your patients that they cannot lay down, they can't work out, any of those things after neurotoxins. If you are, you're compounding on the myth, and you're getting the word out that is completely inaccurate. There is no research to show that there's any issues from laying down after getting neurotoxins. Why? Doesn't make any sense. When you're actually up, you actually have gravity that could potentially move it. When you're laying down, it should be just stable. But that's not really the reason why. Yeah. You guys really, if you don't know that, make sure you go and understand why that is. The neurotoxins after laying down is a complete myth.
Yeah, it's not going to be. That's probably one of those wives' tales, or one of those false statements that somebody made up on podium years ago, and then everybody just went with it. And we know laying down makes no difference in the effect. Same with not working out. I tell my patients tell my patients to wait 2 hours. What do you tell them? Anything? I tell them 2 hours.
I go work out after I get my toxin done.
I know you do.
And I've been doing it for 20 years.
So
no, that is a complete myth as well.
So what we don't want to happen is we don't want vasodilatation and extravasation of the neuromodulator. We don't want it to go places we don't want it, right? So you don't want to cause a lot of extra.
What is vasodilation going to do even? It's intramuscular.
Right, but I think what they're thinking is before it gets caught up in the motor end plate. I don't know what. But anyway, here's what I tell my patients: 2 hours. Why do I say 2 hours? Because it takes 90 minutes for the neuromodulator to be irreversibly bound in that nerve ending, in the motor end plate. it can't go anywhere. So I just say, okay, let it get soaked in, let it get stuck in there, and then go do whatever you want. So you tell them to work out when immediately afterwards. Whatever.
I tell them you can do whatever the hell you want. Just don't touch my toxin areas. Don't push it to somewhere I don't want it to go. Because if you do, that's on you, that you get a toesies or something like that, or a droopy brow because you pushed it somewhere it didn't want to go. So if they come in wearing a hat, I tell them don't wear that hat leaving because I don't want you pushing on it. Until the neurotoxin all binds into your muscle, that's all I care about.
Right.
Period.
And Lynn is asking a question about icing, and they're saying icing reduces uptake. Now, if you think about icing an area, it's going to cause vasoconstriction, right? So everybody's like, oh yeah, they'll bleed less if you ice it. But there is always a rebound vasodilatation. So be careful about that. That's why I don't ice. It's because there's a bigger risk for a bigger bruise with the rebounding vasodilatation that occurs. So just kind of think about that.
That's another myth.
Yeah.
The icing constricts it right at that time. Homeostasis by the body will cause a vasodilatation, which causes the blood vessel to get bigger. So if you're going to ice your patients, don't give it to them 5-10 minutes before you walk in the room. You should be icing them right before you inject them, because
not let it vasodilatate.
So that it does not dilatate. Yeah. What does Lori say? I would think it's more related to if they are laying down immediately after. Nope.
I don't know. It's false anyway. It's a myth.
All false.
They can lay down.
It's all myth.
Yeah.
Effectiveness though, not risk of bruising. That doesn't have anything to do with science and
maybe comfort,
effectiveness of your treatment. Scientifically does not make any sense.
Yeah.
As far as icing, icing doesn't do anything as far as as far as my consideration. I mean, effectiveness, the only thing you could think of if you're really down the road of vasodilatation is icing will create more vasodilation later on, so maybe it draws out more of the toxin of the area, but
or causes more interstitial wash away, or I don't know.
But I would say nope.
Yeah.
I've done it all through the years. Ice them a lot before. Tell them to ice afterwards and things like that. I don't see any effect on effectiveness with regards to that. Moving the areas of treatment repetitively for 4 hours.
Okay, there's more research on this, which yes, it does show that it does help it to become more effective more quickly, which is interesting because we've never really told people to move. Well,
I mean, if you think of it, the science does prove a little bit of that. So yes, up to a certain point, because if you have toxin hanging around the motor MP and you're utilizing it and you're moving the muscle, you're shooting acetylcholine out, which means you're going to have to absorb more because of the actual mechanisms that are going on to make your muscles move. So there could be a potential of more absorption of toxin into a faster rate in that aspect of it. Lisa, what about laying down on your face for like a massage? Well, is that going to push on the neurotoxin areas? If it is, then do not do it.
Then wait a couple hours.
Wait about 2 hours to 3 hours because you want all the neurotoxin to absorb into the motor end plates before you do anything. After that, I tell them you can do anything you want after that. But for the first 2 to 3 hours, it is something where you just don't want to massage or push on those areas so you don't move it to somewhere else.
Yeah. They can do facial motor movements, that's fine. Just facial muscle movements. It might help it kick in a little sooner too.
Cool. All right.
All right. So pre and post treatment care with neurotoxins. Avoid alcohol, aspirin, ibuprofen, supplements for about a week before after treatment, which helps minimize bruising or bleeding. Now, patients are going to bleed and bruise for one reason only. If we put the needle in the vein, right, it's going to make it leak. So if we have a prolonged clotting time prior to us poking a hole in their vein or artery, then that is going to cause a greater amount of leakage before the body clots it off. So the reason you don't want them to take the aspirin if it's not prescribed, aspirin, blood thinners, if they're not prescribed, but like alcohol for about 5 days, Motrin for 5 days, some of the supplements, vitamin E, fish oils, things like that happen to kind of thin down the blood a little bit. That will help to reduce maybe the size of a bruise they might get, as opposed to letting it have a slower clotting time. And then limiting caffeine. I see this everywhere. Why in the world would caffeine have anything to do? I took this off of my consents, actually, because it was stupid. High sodium, high sugar, stupid. Cigarettes 24 to 48 hours before. Cigarettes cause vasoconstriction. So I'm not sure why that would have anything to do with bruising or anything. Arnica 1 to 2 weeks before. Now keep in mind, arnica helps with swelling, not so much with bruising. It's bromelain from pineapples that really help to pull the bruising away, and then Elastin has a product called Enhance that really helps take the blood out of the tissue. But bromelain is more for swelling, and people say arnica is more for swelling. But 1 to 2 weeks, people always tell they come in, they're like, I took my arnica. I'm like, yeah, whatever. Great. Okay. Have fun.
I mean, at the end of the day, remember, you may bruise a patient. If they did all of this stuff, alcohol, ibuprofen, blah, 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 oh, well. Yeah. You just tell them, if I bump into a blood vessel, you may get a little bigger bruise. Is that going to stop you from doing it? No. I mean, this doesn't make any sense in my mind. If you set the expectation correctly, you set the expectation, right?
Yeah.
I mean, it doesn't make any sense why you're like, oh, you did that? Oh, no. Okay. There's no reason to freak out. You just tell them, oh, well, yeah, maybe if we bump into a little blood vessel, you may bleed a little bit more. Okay. Yeah. That's about it.
That's it.
There's nothing to freak out about. So pretty much neurotoxins is very, very easy. I mean, my post-care is just don't massage the area or manipulate the area for about 2 to 3 hours.
Just leave it alone.
That's it.
Just do your normal stuff and leave it alone.
Don't do anything for the next 3 hours, like a massage or anything like that, or a facial right afterwards, and you should be good.
Teresa has a comment about a dermatologist told her that you're resistant to Botox Dysport Xeomin, which is the same molecule, because the patient intermittently fasts. Said these neuromodulators don't work on her. Has nothing to do with intermittent fasting.
No. You have formed neutralizing antibodies, and unfortunately, in your case, don't touch your neurotoxins for at least 5 years. I would probably say. I mean, I say at least 1 or 2. I have like 7 or 8 patients, and I've tried on 2 or 3 of them after like 2 years, 3 years, and the toxin still didn't work.
Keep in mind, neuromodulators are like getting a vaccine. Every time you get Botox, Dysport, whatever, botulinum toxin type A, it is like getting a vaccine. Your body's going to mount an antibody response to it. Mm-hmm. So the more frequently you get this neuromodulator, and or the higher the dose you get, the more apt you are to build neutralizing antibodies to it. So because of new research that's out that shows that we can build up neutralizing antibodies at any time, but it is more likely to build up if we inject more frequently than every 3 months or inject high dosages. I now will separate my neuromodulator dosages at least 3 months apart. I will not do it like glabella this month, Frontalis next month, and Crow's next month so that they can afford it. It's not going to happen, because what I don't want to do is like give them a vaccine every month and then the body is like, oh, I keep getting insulted with this. I'm going to mount a big antibody response, and that's the neutralizing antibodies. Yep. And what I tell my patients is, you know what, I want to be very careful. I don't want this to build up in you. It could happen. I just don't want to I don't want to trigger this in you. So we are going to have your neuromodulators 3 months from themselves. And because if this happens, nothing will work on you. It doesn't have to do with the brand. It has to do with the protein itself, or like sometimes you say accessory proteins.
But I mean, there's arguments.
Nothing will work. No brand will work.
Yes, once you are that way, then yes. So to me, ultimately, you know, the Xeomin has been out there and it says it's a naked protein. There is a theory that the accessory proteins is more of the antigenic component of the response for the neutralizing antibody. So ultimately, you put out the neutralizing antibody, it goes, it pokes at it, it's like having the good kids and the bad kids play together, and the bad kids are the ones that create the incident, and unfortunately, because all the kids are together, they all get wiped out. They all get in trouble. And so the core protein is thought to be not as antigenic in its character, thereby, and that's what Zeomin is saying, is that thereby there's less potential of neutralizing antibodies with regards to Zeomin.
But what's interesting about that theory, and it's still left, we don't exactly know, but when you mix your neuromodulators with normal saline.
Well, no, because you're injecting the accessory protein with it.
Right. So we don't, but what's interesting is, like, if somebody's had, say, Botox, and you've got a 900 kilodalton molecule that you're injecting, and 150 kilodaltons is the actual protein, the Botox protein. So you give that to them, and they develop neutralizing antibodies.
Yep.
So you go to try Zeomin or Daxxify, which are naked proteins, they're 150 kilodaltons, and that's not going to work either.
Yep.
So if it's an antibody to the accessory protein.
No, because what happens is the good people are the core neurotoxins. The bad people are the accessories. The bad people create the incident. Everybody gets involved because it's all injected at the same time.
But the accessory proteins are different for each product.
But it doesn't matter
specific.
because it spikes the actual process. Because now it's not that, because that product caused the neutralizing antibodies to not only form against the accessory, but also the core protein.
That could be.
And thereby every core protein gets knocked out. That's the reason why.
It's interesting. Well, if the antibodies are being built against two different things at one time.
Well, yeah, because they're all presented at the same time.
Could be.
It's all being presented.
It'll be interesting to see.
That makes sense. It's the running theory. It's not the fact that they're different. It's the core protein is the same of them all, but when you throw out the neutralizing antibodies are thrown out because of the fact that the accessory proteins instigated the body to respond. When the body responds, it doesn't just affect the accessory protein, it affects all the protein.
So what I would like to know, and I'm sure somebody knows this, is if there's ever been a patient who's only had a bare protein, and if they've ever developed neutralizing antibodies.
You would have to ask MERS.
Right?
I don't think they have one yet.
That would be interesting. If you know someone's only
So that would be something where, if you're talking about your patient, this is where you go into your younger patients who are doing a lot of lip flips. I know a lot of you guys are probably doing lip flips, and they're coming every 4 to 6 weeks. It may be more advisable to consider just using Zeomin on those type of patients and seeing if they ever develop it. Because that's the whole thing, is if they're using other toxins early on, by the time maybe they reach 30, 40 years old and they need it for all of the areas, have you primed the body to mount a response that now when they really need to use it, they don't use it. And it's not going to happen to everybody, but it does happen.
Christina was asking about research on resistance. Yeah, there's a lot of research out there on antibody resistance and neutralizing antibodies on neuromodulators. So feel free to look those up and show those to your boss.
Yes.
Patricia, and I can't remember her last name. I was with her at Beauty Through Science last year. She's from Germany, and she's done a lot of research on it. And she kind of states that you need to wait a year before trying it again. And you've rated 2 or 3 years, and it hasn't worked.
Like 2, 3
but
years
those antibodies have to wane. They have to forget about the insult, and then they'll work again. So Patricia, and I'm trying to remember her last, started with G, I think.
And how lucky you respond to MyoBlock in case of antibody. MyoBlock actually is very different because remember, it's a type B and not a type A, so it works on a completely different receptor. So yes, MyoBlock will work. It's just MyoBlock is so short acting, they have to constantly get it done, and it's hard to get MyoBlock. And
it's painful, right? It's supposed to be painful.
MyoBlock is much more painful in that aspect of it.
5 days no alcohol, just because it's a blood thinner. That's all. Yeah, it leaves your system. You're not drunk anymore, but it doesn't mean it doesn't thin your blood.
It doesn't mean that it already hasn't affected your body from producing
It's like aspirin.
less platelets.
Aspirin works for the life of the platelet.
Yes,
it's irreversible for the life of the platelet. So it's like 5 days or so, however long a platelet lives. Anyway, all right. So we're going to go to product recommendations. I mentioned something about bruising. that Alastin has this product called Enhance, and we give this to all of our patients that are getting, say, lip injectables and such in a little container. We just put a little bit in a container and give it to them, and they put it on as like a lip gloss, and their any bruising goes away so quickly with this. So it's one of those things that will help actually kind of carry the red blood cells away rather than just stop inflammation like arnica does. The other thing is I give them pineapple tea. We give them like 3 or 4 tea bags. It's pineapple tea, and it's got bromelain in it, and it works amazing. So that's a new one. I didn't tell you about that.
No.
Yeah, I have to tell you.
Pineapple
Personally,
tea?
I figured that out.
Oh, that's very
Yeah,
good.
amazing.
Cool.
Yeah.
All right, HA fillers, myths versus facts. Sleeping on your side after injections will migrate your filler.
It might flatten it if it's a little bit. I tell people try not to, only because it might flatten it or shape it differently.
Majority of you guys are sleeping on hopefully what we consider soft
Right.
pillows, and you're not sitting
Yeah.
there and like
Right.
rubbing your face on there. I mean, to really move and flatten a filler, I mean, I have to give it a little firm push. So yeah, I don't believe that. But I mean, there will always be people. There's always a potential. In a sense, I won't give that it's completely out in left field, but it doesn't necessarily make sense if you are sleeping even on your face. It's not like the pillow is a hard rock and you're moving so much that you're like grinding it down and flattening it out.
Yeah.
So
I haven't had anybody come and complain, and I know everybody's not sleeping on their back.
I know. I mean, 20 years injecting.
Yeah.
Probably close.
Never had a
I probably
problem.
injected.
I've not
probably
had anybody
over
come back and go, this side's
50,000.
flat. I haven't had anybody say that, and I know people sleep on their
Yes,
side,
no.
so maybe not as big of a deal.
You have to sleep sitting up after injections? No, you don't. You
no.
know, if you feel as though you overly inflame the face because you traumatize the face, then maybe
Like threads.
a
I have 'em
pillow
yeah.
just to drain them, or give them a little water pill to drain them, or put them on a little. Sometimes my patients who are complaining about like a radius, the swelling, I give them 40 milligrams of prednisone and knocks that out very, very quickly, and they don't actually hold on to the swelling very much. So you can definitely do that.
Making facial expressions, no. It's not going to hurt your fillers.
Not gonna ruin your fillers. I mean, especially with the newer fillers that are like Restylane has the expression technology. They're supposed to be stretchy anyways.
Yeah.
So you're not gonna ruin your fillers with regards to that. Maureen says, now that mineral modulators are being used not cosmetic but therapeutic, person, we need to be good stewards for sure. And that's one of the big things that we don't understand is cosmetic. We think everyone's using cosmetic, but I mean, literally the therapeutic aspects of it too are huge. I mean,
the doses are huge.
The dosage are a lot huger, and when we know in the research, when you're using larger dosage, that is where you have the higher potentials of seeing these neutralizing antibodies.
Right.
I mean, and we're doing it for migraines. You need it for migraines for those that really, really depend on it. I mean, and then traps are amazing to shrink those down. People use it for low back pain. They use it for a lot of different things.
Guess what I had come into me last week?
What?
A patient with cervical dystonia.
Really?
That's what Dysport was kind of made. It's dystonia in a port of Sweden or whatever. So it's like that's how Dysport was made, was cervical dystonia, and I'm like, whoa, this is perfect.
That's cool.
This is perfect.
That's really cool.
That's exactly why it was named. Oh, it's just one of those weird things I wanted to tell you.
All right. Alcohol treatments, aspirins, ibuprofen.
Yeah.
Same thing. HA fillers. Really, it's about the potential of the bruise.
Yeah.
Talking to the patients. I always tell my patients, especially lips, you're going to bruise. Nothing to it. But the caffeine, all of that I don't think that makes any difference. I think post-treatment is pretty much the same as your neurotoxins. The arnica, the bromelain is more important. The Enhance is a great thing that does help on that aspect of it. I think that's probably about it as far as post-treatment. I think setting up the expectation on HA fillers that you're going to swell for the first 2 to 3 days. I really emphasize this, especially with lips and other fillers. You're going to swell for the first 2 to 3 days. It's going to look a little odd. Then you're going to get used to it, and you're going to kind of say, Either you love it or you're like, ooh, maybe it's a little too much. If you love it the first week, then I guarantee in the second or third week, you're going to come back and say that your filler's gone. And I'm going to tell you it's because you need more because you didn't put enough in the first time. And that's okay. We can add into it and keep adding to it. If they hate it or they think it's too much the first week, by the second or third week, they're going to love it. So I really do emphasize that. It's part of the expectation, and I think it's huge part of your post-treatment is setting the expectation correctly on that.
Right.
Okay.
We're going to go to PowerPoint.
All right.
All right, so we talked about the benefits of Enhance, which is really, really nice. We really like that a lot. Microneedling, what are some of the myths and facts with microneedling? Now, microneedling causes permanent holes in your skin. There's one time when this can happen, and that's when you're dead. Right?
It's true.
Seriously?
I mean, that the whole goal of microneedling is collagen induction therapy. You are causing, essentially what lasers are doing, you are causing a controlled amount of damage to force the body to do something to it. The results are permanent. Nothing in life is permanent. Only, what's the joke is taxes and death.
There you go.
Those are the only two permanent things. And in our field of aesthetic medicine, you don't want anything that is permanent. I mean, even in surgery, nothing is permanent. I hear that all day long from my patients. Like, why doesn't that last for a long, long time? I'm like, because if it did, you wouldn't like the way it looked when you aged 10 years in the other areas that you did not treat.
Yeah.
I mean, this is the problem. People don't think about it. They think they only age in that one area. Well, they're aging in the whole face. And this is the reason why we go back to understanding that we need to treat every single level. Mm-hmm. Every single level of the face is aging. The bone, the fat, the muscle, the fat, and the skin. And so you just don't want to do anything that's permanent. And so nothing in life is permanent because we keep changing. Even bone is not. Bone resorbs and grows. It's an active tissue as well. Okay? Microneedling isn't safe around eyes or lips. That's false. You have collagen around that area. Why wouldn't you?
Yeah,
that's
works really
a great area to do it. You know, the big things with microneedling to me is what are you trying to accomplish with microneedling? I think people overdo microneedling. They get way too deep. You don't need to.
They want blood.
2.5. You want blood. That is actually bad.
You don't need
You're
that.
overdoing it, guys. Everything you guys are doing is like getting all bloody and bloody and bloody. Why are you doing that? That is not the purpose of microneedling. Only in the cases like acne scars where you need to get deep enough to create trauma for those acne scars do you need to do that. The rest of you guys, if you're just doing microneedling for overall skin quality and rejuvenation, you should not have barely any pinpoint bleeding.
Yeah.
But that's for another time.
That's another topic.
All right.
Pre and post care for microneedling. Avoid sun exposure. Yep. Tanning beds. That's good. I like that. Avoid irritating products. I agree. You know, don't do anything crazy on your skin and before you're going to be putting a bunch of holes in it.
Yep.
No waxing or depilatory creams for 1 to 2 weeks.
Anything that creates irritation.
Don't do anything that irritates it. Yeah. Yep. And the cold sores or fever blisters is really important for patients to let us know about, because if we're doing microneedling or lip injections and they have perioral HSV, then that could definitely wake up a sleeping beast. And we'll throw these people on acyclovir or valcyclovir the day before so that it can kind of decrease the occurrence and severity and duration of the cold sore or fever blister.
Heather says she had that happen to her. She has a perfect circle of needles that is identical to the microneedling pen. It was done 5 years ago. Now, I will definitely say there are pens that are not as great out there and can drag and create more scar tissue and tearing into the skin than other ones that actually go in and out, and really are much more gentle on it. I mean, this is why I'm not a big fan of those rolling ones as much, especially the deeper ones. The light superficial ones, completely, those are fine. But the deeper ones, I mean, if you imagine, it goes deep in the skin, and as it's rolling out, it's literally tearing the skin up. You have to realize it's about controlling what you're doing with your treatment. This goes into understanding the why. So if you got a perfect circle that looks like needles that is identical to the microneedling pen, then you have to wonder what type of microneedling pen did they do? What did they really do? Because
how long did they leave it there?
If they really just left it there,
Dug
then
holes
yeah,
in.
you can potentially create scar tissue into the area.
That's really uncommon, though. I'm sorry that happened.
I've seen scrapes, like
I've seen
really
excoriation.
a lot of excoriations from
me
that,
too.
and that's really just bad microneedling pen, as far as and bad microneedling in general.
I agree.
You should not be moving it like this.
Yeah.
It should be moving in a nice, consistent
Slow, nice and slow.
Expect erythema, redness, swelling for sure. You can definitely add other things, exosomes, all of those things that help decrease inflammation or in repair. Hydration is important. Growth factors, stimulating skin for rehabilitation, avoiding makeup for sure. Gentle products, yes. All the other irritating things, you probably want to wait about a week, even up to 2 weeks before you want the skin to repair. Remember, it takes at least 2 to 3 weeks for the body to start really forming that collagen that lays into the area for the repair aspect of it. So really take care of microneedling as if it were you can say a trauma, like a scab. How would you take care of a scab? It's gonna be tiny little things. I feel as when I get done, it feels like sandpaper for the next couple of days. Once it heals off, I do a light scrub because my skin needs that scrub to scrub it off. Otherwise, I'll develop acne. But ultimately, you can just hydrate, and really get your skin with some nice things into it.
So why do we say avoid applying makeup for 24 hours or anything else? It takes about 18 to 24 hours for the small little holes to seal up.
Yeah.
So try to have them not to avoid something just for that 24-hour period. And then once the little holes seal up, kind of like doing toxins or fillers, then they can do whatever they want.
Yep.
Yeah.
All right. Product recommendations, microneedling, all of this stuff is there.
Okay, so I don't know if you have this.
I
I don't know if you have this in your packages or not, but when I do microneedling or anything that's a collagen induction package, the one that you see on the left, the elastin nectar, is something that is in all of my packages. They don't have a choice to get it or not; they get it. This product will help to clear out the extracellular matrix with all the old fibrins and all the old collagen muckalucks that are kind of jamming up the system. It helps clear that out, and it helps new fibroblasts grow with new collagen. So if I can clear out the old stuff 2 weeks before I get them started on microneedling or whatever I'm going to do, either RF or regular microneedling, then I get them started on this nectar, and this is going to help enhance them building that collagen. So it kind of clears out the drain, and then it allows me to build more collagen. So if anything, this product helps the outcome of my radio frequency microneedling and my regular microneedling quite a bit. Now you have them use it for CO2s also. Yeah. And then the Trihex helps build collagen. So anyway, that's excellent. But the nectar is what I use for procedures.
All right.
Lasers or peels?
Lasers thin your skin.
I hear this all the time.
I know.
They do if you're dead. A lot of this stuff, a lot of these myths are when you're dead.
And I think the lasers that thin your skin goes back to the pre-Wii days when they did fully ablative lasers, and they literally just wiped out the skin. And those are the patients who you see have that line of demarcation. They look like that glassy fake skin. You probably don't see very much of them because majority of those patients are probably in the grave now.
Yeah, a lot of
majority of people do not do any ablative treatments anymore. Majority are going to be fractional type of treatments that are out there in that sense.
Sun after a laser? No.
Yeah.
Nope. Any damaged skin can have a more intense reaction to UV light and have post-inflammatory hyperpigmentation. Pigmentation. Even a light skin can do it.
Remember, your skin is being damaged. Your body doesn't know what is damaged. So what it's doing is it's sending everything, all the signaling factors to get every part of the skin repaired. And that's part of that. Now you add some UV onto that body's going to go, oh, there's even more damage here. It's going to send more of those cells to the area to start to repair the area, and that's how you get your hyperpigmentation and all of that stuff. It's part of the body's repair system. Yes, it's an adverse thing, so that's the reason why you want to mitigate it and protect the skin in that sense. Darker skin tones can't get laser treatments or peels. That's false.
Yeah.
They can totally do that. You just need to understand, going back to laser physics, what lasers work on melanin, what lasers work on hemoglobin, what lasers work on CO2, the chromophores of the skin. If you don't understand what I just talked about, you need to go and learn about laser physics, because that is the base of all lasers. If you don't understand that, please go get educated about lasers. If you are already doing lasers and you did not understand what a chromophore is and all that stuff, we have a nice webinar that goes over that, but really delve into lasers, please, on that aspect of it. Okay? Pre-treatments, of course, skin brighteners to mitigate.
I do that all the time.
Yep.
For my patients.
Yep.
Put them on a pigment inhibitor
Avoid
before
sun exposure before and after. There's pre-kits, post-kits that should be sold. Sometimes prescribing medications for more aggressive treatments like acyclovir. I put them on a steroid sometimes when I'm getting aggressive. On those aspects of it. Post-treatment depends on how aggressive you do. Expect some swelling, discomfort, certain things. Definitely tell them do not peel, do not rub, do not scrub the area until it is ready. Otherwise, you're going to expose brand new skin before it's ready to be exposed, and then you're going to create more of scar tissues and having a lot more issues with regards to that. Daily sunscreens, all of those things are going to be important. Make sure that you are hydrating, all of those things.
Hats are imperative.
Yeah. Okay.
Yeah.
So that's lasers. And of course.
This is the one on the far right, which is the Illuminate by Elastin. That is a pigment inhibitor that has tranexamic acid in it. And there was a head-to-head study with this and 4% hydroquinone that was done over 12 weeks in the summer, and this had better pigment inhibition.
Yeah, this one's a great
And this is even safe for pregnant and breastfeeding. So it's safe for long-term use. So I have a lot of my patients on this every day and night. Yeah, it's a good one.
All right.
Lasers and peels. Are PDO threads visible under the skin, even only if they're not done well?
Yes, PDO threads, if they're not done well,
Yep.
What's going on, guys?
Yep. And they don't, PDO threads don't require extensive downtime. They're swollen for a week or so, and they're tender, but
they're tender for about 2 weeks. I got them done. You got them done.
Yeah.
I mean, they're tender, but they're not horrible. They're a great way of repositioning. It is not going to get you a facelift. It is going to get you a nice, you say perk. We're addressing one tissue plane, the subcutaneous fat. It is not even addressing skin. So you guys that are talking to your patients say, oh, it's going to lift your skin. Please do not do that. You're going to get the wrong impression to patients. PDO threads reposition fat. Unless you're doing smooth threads, then you're working on skin quality, collagen stimulation, all those things. But that goes into really understanding PDO threads. That's a whole slew of education that you guys need to get if you want to jump into PDO threads. It is a higher learning curve than even fillers and toxins.
I don't know about you, but it's my favorite thing to do.
It is amazing.
It's my favorite treatment to do.
Are so fun with regards to it. So that's
and it's not for faces only. That's a myth.
Yes.
We put them in elbows, knees, necks, and we put PDO through.
Butts. You can.
So we can put them anywhere. Smooth threads are collagen building. Barbed threads are more for lifting and approximating, which is nice.
Yeah. Pre-treatment, taking oral antihistamines, starting maybe a little steroids, discontinue things that, of course, minimizing bruising and bleeding. But honestly, I don't get very much bruising or bleeding very much.
Yeah.
It's more of just swelling afterwards. Post-treatment, really a little bit of icing. I actually tell patients I give my patients some prednisone. I don't give them antibiotics. Pain relievers, Advil, ibuprofen.
Maybe,
800 milligrams. I tell them every 6 hours, don't even let go. Every 6 hours for the first week, just to decrease inflammation and help out with regards to that. And then they just want to minimize the amount of activity and movement. If you're bouncing up and down, opening your mouth really big, you're going to loosen up the threads. And the when they leave my practice, I tell them this is the tightest it's going to be. It's like buying a brand new tight pair of skinny jeans, and then after you live in it, it's going to stretch out, form fit to you, and be nice and form fitting. Just not as tight as the original.
Yeah.
All right.
And ask them to not put anything on their face but soap and water for the first 48 hours, because it takes longer for a cannula hole to close up than a needle hole.
Yes.
So I asked them to not do it for a couple days.
Yes.
We have time for like one. Are we?
I know. We have time for like one question. Sorry, guys.
We have
There's a lot
time for
of things
one
that
question.
we do. Go down, guys.
Other questions down there? Let me see.
I wish I could answer all of your
I
questions,
know.
but that's why we have our mentorship program. If you want, that's why we throw it out there so that you guys can get a lot of different help with regards to that.
Can you do microneedling and pico laser together?
Sure.
Yeah.
Yeah. I do that all the time. I do my Hollywood peel, my Q-switch laser, which is very similar to a pico, and then I do microneedling right afterwards.
Yeah.
I love it. Stacking the hack is the name of the game. And that's why the webinar that we're going to do is going to be really cool. All right, they're pulling our plug, guys.
Okay.
March 5th at 5 p.m. What were we going to talk about? I forgot. What is the next webinar about?
Oh, I think it's
mental health.
Mental health
and aesthetics.
Yeah.
So we're going to talk about how that really is a part of aesthetics and how we affect our patients, both
And what to
positively
assess,
and negatively.
what to assess for. Some of the red flags, some of the things we want to assess for, and how we can really connect with them and help our patients, and how some of the medical aesthetic procedures that we do really help with mental health.
All right. Have a great month, guys.
We will
and
see you
see you out there
next month. Bye, guys. Thanks for joining.
Bye, guys.